To meet you. I understand today is your last session. So usually I get to interact with participants much before this. But anyway, let's move on to the session. Today I'll be talking about a little bit about end of life care, and I'll try to share most of this is evidence based and connecting to the experience that I have in the past in working with patients who are dying, and we'll be touching upon a little bit on medical ethics. So I hope this can be an interactive session because, as you all know, many a times the medical ethics decision making and end of life care is very subjective, or there are certain areas where there is no clear cut answer, but it is mainly meant for discussion. So I'll just start my presentation. Yeah. So the first question, very, very important question. Are you able to think about your own death? I would like to see some hands. Anyone who have already thought or don't want to think or not thought or not sure whether we can think about it. I'd like to see some. You can go to the reactions and put some hands up. Yes, I can see Shiny. Shiny has thought about uh, own death. What about others? Anyone else? Sister Philomena, Sister Rosama, Wendy, Sister Rosella. Do we think about our own death? Oh my God, only one person? I don't think that's true. Then it is, I think, then it is high time we start thinking about our own death. You know why? Because then only we will be understanding or think what our patients want. We'll be able to empathize more if we are able to think. So these are the common trajectories that we see in patients who are dying, or any one of us, or I hope at least all of us believe that we are all going to die, right? Or in this group, I think that part we have some consensus. Everyone in this group is going to die one day or the other. We don't know which trajectory we are following, right? These are the trajectories. Invariably, all of us will fall into one of these trajectories. The first one is sudden death. That's very highly unlikely that we follow that trajectory. Only 10% of people can have that fortunate opportunity to have a sudden death. Example would be a road traffic accident. You are healthy, you're walking on the road, you have an accident, and you have a serious injury, and then you have a sudden death. That is one scenario of sudden death. The other is a terminal illness. For example, someone diagnosed with advanced cancer. I'm not telling any cancer, advanced cancer. What happens there? Their health, quality of health will be very good, quality of life will be good, health will be good. And then when the diagnosis comes with an advanced cancer, then there is a sudden decline, right? The death is not as rapid as the road traffic accident death, but little bit of gradual, but they die pretty fast after diagnosis. What happens in end stage lung disease or kidney failure or heart failure? They will have deteriorating health. In between, their health condition will worsen. In between, if you take an example of COPD, patients with COPD or heart failure, they'll be on medication. In between, they will have an exacerbation. Then they will be hospitalized. Once they are back from the hospital, their quality of life will not be as good as before admission. There will be sudden, slight deterioration. Again, a few months will go like that. Suddenly, they will have another acute illness. They will go for hospitalization. So, gradually, there is a decline. In between, there are acute exacerbations. So, the third picture is more for organ failures. The fourth is frailty. So, you can see it started with low quality of health. For example, in elderly, right? They will be pretty weak with age related weaknesses will be there and they decline gradually and leading to death. So the patients with dementia also follow similar trajectory of frailty. So invariably, all of us will come into one of this trajectory for sure. So first question was, have you thought about your death? If you have not started talking about or thought about our own death, then this is the best time to start talking about it. Because why? Once we start accepting our own mortality, then we know how to value our own life and live meaningfully. Maybe most of you are already doing it, but once you know that this is okay, invariably this is going to happen, then we know how to live our life meaningfully. Again, we will be able to empathize what others are going through when they are going towards the end of life situation. And maybe with the better planning, we'll be able to die as well as possible if we start planning early. Now we know people talk a lot about advanced care planning, writing living wills, writing your own medical wishes or decisions. So if we plan ahead, maybe we'll be able to die as well as possible. So how generally, so this is written by a Bengali doctor based in UK. So this is a situation that he describes which happens in India. When the patient is really poor, they don't know about these facilities, right? They don't know about, okay, how they can die or can they go to hospital? How will they go to hospital? So the poor die in misery of neglect or they are not taken care of very well because of their poverty. What happens to the middle class? The middle class die in the misery of ignorance. They don't know when to take the treatment or when to approach or what kind of treatment they should get or where they should go. And what happens to the rich? The rich die in the misery on ventilators because they have money. And I will add that it is not just about rich people. Most of the healthcare workers, including doctors, will die in the misery of ventilators. Or if you have a doctor, son or a daughter or an uncle or a husband, then there is a high chance that we die on ventilators because more the knowledge I think we have, we think that we can be saved forever. Or mortality is not something which affects me and no one gets a pain-free and dignified death. So this is what he has written, and which is very, very true. If you think about many situations, if you take I am sure all of you are seeing patients on a day-to-day basis. This is very true in an Indian context. So what should I do as a nurse or a doctor or any healthcare professional? What is the first priority when I am taking care of patients who are dying? First and foremost, the patient should be or the person should be as comfortable as possible. And I'm not talking about the comfort, physical comfort, but emotionally, socially, and spiritually. I'll come to each in detail in the coming slides. But the primary motto when you take care of someone who is dying is to make them as comfortable as possible. And I think it is many a times people or my colleagues ask me, isn't it depressing to work with people who are dying? How can you encounter death almost every day? But I think that is the time they need more attention from us because in hospitals they may not be cared because they are not someone who gets cured and go back home healthy. And that is a very precious time. We celebrate birth a lot, right? Someone coming to the earth, we celebrate it like anything. This is the time that they are leaving the earth, so it has to be as comfortable and peaceful as possible. And I consider it as a privilege if you can work or if you can provide some kind of comfort for people who are dying, because that creates a mark in their family. They'll always remember you if you have given help the patient to have a comfortable life. What are the priorities? Again, this is for ourselves also. If we start thinking about life, deaths, our own death, what is your priority? What would be what would be the most important things for me in the last month? Maybe I will want, no matter how grown up I am, I might want my mother to be with me because I'll be scared. I don't know what all symptoms are going to affect me. I will definitely want to see my kids and to talk to them, should be able to talk to them even if I know that I'm dying. Some people want to pray, or some people want to do some religious process to make them feel at peace. Maybe see some relatives, talk to them. Nowadays, it is easier, no? You can make a video call and have a conversation. It was not that easy in the past. So it is very important to understand what is the most important part for me in the last time. So it is also important to ask that same question or explore it in your own patients also. What matters most to them? It may not be your medication. No one will remember what medication you give, but they will remember what experience they gave when they are dying. So coming to the objectives in detail, it is not just about the patient, it is to the family also. They should be adequately informed on status and goals of care. How many times we beat around the bush when you talk about death? Things are not really great, or this is God's way of telling you. So many metaphors we use. We never use the term death. It is very, very important to get familiarized. If you are not using that term yet, start practicing it. Because no, many a times when you say things are not really great, they are not expecting death. They think, okay, there is some deterioration, he will come back. It is very important to start using the term death, nearing death, or moving towards death, and the patient and the family should be adequately informed. And your goals of care changes, right? Your goal of care is now comfort. Your goal of care is giving peace and comfort to the patient and the family. You are not focusing on a rehabilitation. You are not focusing on sending him back home or making him back to normal. So it is very important to have the conversation, especially document goals of care. These are the goals of care. Number one, providing comfort in the flight or comfort care when someone is dying. And make them aware of the signs and symptoms and the time course. Many a times they don't know how generally, how many of us are very clear about the whole dying process. What all changes we see in patients. All the patients may not follow the same signs and symptoms, but by and large, the signs and symptoms are very commonly seen. It is very important to train them. In the coming days, there can be more changes in the respiration. In the coming days, there can be change in the body temperature. There can be change in the urine output. So make them adequately aware of signs and symptoms. And again, the very important question everyone will ask you when you have the end of life conversation, how long do you think he's going to live? How will you answer? Doctor, is it going to be a week, a month, a year? Because last week, I mean, 2 weeks back, I had the same conversation. The son has traveled by air to see the father. Father is dying, and he wants to see whether he wants to stay back or go and come again. So, how long do you think this is going to take? So, we have to say that this is unpredictable, but by and large, these are the signs and symptoms. This sign is showing that it may be. So there are certain prognostication tools which you can use. So they say if the patient has taken weeks to reach from the normal functioning stage to the particular state, then the end of life is going to be in weeks. If he has deteriorated in days, then probably some more days. So if the deterioration happened in hours, then probably it is few more hours. That's the general prognostication that we use. There are a lot of tools, but always tell them, although we tell all this, it is very unpredictable. But they want to get some answers from you. And we have to prepare them what to do if unexpected events happen. What if the patient starts having delirium, all of a sudden, a lot of hallucinations, or very distressing respiratory symptoms? We have to give them a plan. If you see this, give this medication. If it is not controlled, which number to call? Whom to call? Should I rush to hospital or should I call you or should I bring to your hospital? So give clear instructions. Ask whether they know the diagnosis. Many a times when we get patients, they will be gasping and the patient's family has no clue whether they had cancer or not. I'm sure all of you might have seen that. So understand whether they know what is happening, what is the illness, and ask what kind of care, what do they, when they come to you in your palliative care setting, if you are a palliative care or you are in a home care or any setting, they have some ideas, right? If I go there, or their oncologist might have told, you go there, they'll take care of everything. That's the usual referral pattern. You go there, they'll take care of everything. So they might have come with some idea that you're going to take care of certain things. So ask, what do they think? What is their expectation? There should not be any expectation mismatch. They think that you're going to keep the patient alive and while you're giving end of life. There is a clear expectation mismatch. So have the conversation. Ask what is their expectation when they brought the patient to you. Where do they want to take care of this patient when they are dying? Place of care, whether they want to be in a hospice, whether they want to be at home, whether they want to be in a hospital. Do you want any interventions? If some problem arises, either we can manage conservatively or we have to go for interventions. In that case, do you prefer intervention? So all these have to happen not when the patient starts gasping. You can't go with the menu like in a restaurant, okay, chapati, paneer, chicken. No, you can't ask, okay, what do you want? It has to start much earlier. Even for choosing from a hotel menu, will take at least 15-20 minutes, right? And you're asking a life decision. You have to give it. So as early as possible, if you think the patient is going through end of life, it starts months until and unless it is not a sudden death. It is important to have these conversations. Understand where the patient is coming from. Understand the family. So I'll tell you an example. Sometimes we see the son, wife, everyone around. Sometimes the patient might be connected to a cousin brother or who used to be a support system before and he wants to see them. So it's very important to understand the family system. Again, sometimes the decision maker, so especially if it is a male patient, wife invariably is not the decision maker. They ask their sons or the brothers or some uncle in the family. So it is very important to understand who is the decision maker. Again, if wife is not the decision maker, we also have the responsibility to talk to the wife. What happens is that we generally doctors ask, who is there with the patient? Then one male member in the family will come. We'll convey the news to the family that particular person, right? But there is a wife who is taking care of, or there is a daughter who is taking care of this guy at home. So it is important to understand who all should be involved in the conversation. Understand the patient's family structure, where he is coming from, and go much deeper. Understand what is their connection with the world. It can be faith and religion, someone coming from a religious background. Maybe the thing that is connecting them to the world might be faith and religion. It may not be the family members at all. You don't need to think about family members. So I had an opportunity to, so there was a nun who was working in a convent nearby who used to be my son's teacher. And she had an end stage rectal cancer. She wanted to be within the convent, within the along with the other inmates. She never wanted to be in a hospital, but she had severe symptoms which needed some continuous infusion of morphine, etc. But she, from for years and years, she is there in that convent. She wants to be a part of the prayer in the evening, and that makes her life meaningful. So I can't insist on come be in the hospice and take admission. So that religion is something which connects her to the world. So we made sure that she is in that place when she is dying, surrounded by her, the inmates, taken care of by the inmates. But I used to go and change the infusions every now and then. Sometimes people are connected to nature, maybe dogs. Some people have a lot of pets. Maybe they want to be with their pets. They want to be with plants. Like these are all experiences from patients. They were worried about the pets at home. They wanted to see. Sometimes they worry, oh my God, I have a lot of plants. I want to be with them. So understand what is connecting them to the world. Understand the many a times they feel that see now I'm being a burden because I'm dying. And this is the time to give them a life review. What they have done, what good things they have done for the family, what or how they lived their life. So it is a time where you can have all this conversation. Understand more about the patient. Ask these important questions. So now I think you have had sessions on symptom management, this, that, and all. Now you can see how the conversation has changed from that controlling nausea, vomiting, having NSAID related complication. Now you're talking about person's life. What do you want out of your life? Or what is the most meaningful part of your life? And what is the whole purpose of your life? I always ask this question for myself. So I always think Even if I'm so ill, I might want to go to the hospital every day. I might want to be with the team, want to see patients, if possible, talk to some of the patients and family. That in the evening you feel okay, you have some purpose in your life. So it is very different for different people. So understand that. So generally, by and large, when do we think that this patient is dying? Generally, they say if they are under two of any of the following, if they are bedbound, semi-comatose, only able to take sips of fluids, or no longer to take tablets. But it is variable. So even for patients with advanced dementia, you might see these symptoms. That doesn't mean that they might be dying. But by and large, this is something very simple that can be applicable if you are in confusion. So first step is to understand, if you have had a conversation earlier, the patient might have told you where they want to die, what kind of treatment they want to get. So have that conversation with the family. Okay, this is a symptom. Are you able to manage at home, or do you need our support? Are you looking for artificial life support? All these questions have to be asked to the family members. What are the common signs of dying process? So I'll ask the group. What do you see, by and large, in your experience? What are the common signs that you have noticed when you treat patients? I hope you might have seen at least someone dying in your own family, even if not giving end of life care to patients. What are the common issues that you see? Anyone?
The respiration changes.
Yes. Yes.
Cold and clammy skin.
Yes. Very, very, very true. Anyone else?
Low BP.
Yes. Yes. Many signs and symptoms, like
Yeah.
what about feeding? They stop eating?
Yeah, they ready.
They reduced
And
intake, right?
yeah, they feel all the more sleepy.
Yes, exactly. Yes. So it's very important to remember all this. Altered level of consciousness. As you said, abnormal breathing patterns, loss of swallow or gag reflex. So that's why they keep coughing when you try to feed, because the gag reflex is lost. Lot of secretions, oral secretions and tracheal secretions. Some patients, or especially when they have a progressive illness, delirium is very common. And what is most distressing? Loss of sphincter control. Very, very distressing for the patient and the family. Till then, they might have taken care of on their own for months or years. Suddenly, they don't have control over the bowel and bladder, which is actually many patients express their wishes. So I used to have end of life conversations with my parents. So my mother has told that this is something which she can't afford to have, loss of sphincter control. If I am urinating and I'm passing fecal matter in my own clothes, make sure that I'm clean all the time. So these are things which matters a lot. And there are certain cardiac and renal issues. There can be tachycardia. You already said hypotension and cold, clammy extremities. Decreased urine output is very, very commonly seen. So what are the issues that you will encounter? You will have cardiac renal dysfunction, neurological dysfunction. Many a times, I don't know how many of you have heard, sometimes the patient's caregiver, like 2 weeks back, they asked, why is he not closing the eyes? They keep the eyes open. Have you noticed that? They keep the eyes open for a long time. They don't close their eyes. So caregivers will ask you why he's not closing the eyes. Sometimes they experience pain. And what are the things that we need to consider while taking care? They won't be able to move on their own. So they will need more care for activities of daily living, even for position changing or oral care, hair, skin, eye care, activity, all the activities they need more help because they won't be able to move. And they're lying down in the same position for hours and hours. So they'll be having joint position fatigue. So if possible, if it is not painful, give passive range of motion. And we all know that there is an increased risk of pressure ulcers. So even if the patient is dying, even in the last few hours, changing the position, giving proper skin care, I always feel when they are dying, your care should be more frequent. If you are giving position change every 4 hours, or if you are giving skin care, checking the skin every twice a day, once a day, it has to be increased frequency when someone is dying. How will you take care of a child or newborn? We'll take care of their skin very well, right? We will feed them every hour. We'll check if they are okay every hour because it's newborn. And it is the same when someone is dying. The intensity of the frequency of care should be more. And I felt when you engage the family members in this, no, they feel really good. See, the patient will feel that giving a massage by their own daughter or son or a wife, giving a passive range of motion, turning, it is all conveying a language of love. It is not just about preventing pressure sores, it is not just about preventing pain or joint fatigue, anything. It is also about conveying that, okay, you have your own people around you to care. So encourage the family members to do it at home. It is our duty to tell them how to do. Can any of the following be stopped? That is one thing that we need to think. Can we stop some medications? They might be on statins for hyperlipidemia. They might be on diabetic medications. Do we actually need them? Because they are not eating or drinking. Do we really need to check blood for every 4 hourly for blood sugar, etc.? Do we really need to prick them every now and then to see whether they are okay? And are we going to be able to fix it every now and then? And they won't be able to take medications. We cannot stop many medications. If they were on psychiatric medication, if they were on beta blockers for hypertension, these are medications which you cannot stop until and unless they are actively dying. But there are so many medications that we need to consider stopping because it is adding burden. Can we switch to other route? Can we give subcutaneous? If they are not able to manage at home subcutaneous route, can we give certain medications rectally? So, all changing the route of administration is very, very important, and you have to plan ahead because you're preparing the family also, right? So, you have to tell he may not be able to swallow in the coming days. So, that time you can give this medication rectally. So, as I said, nursing care has to change. It is increased frequency. It is not the other way around. Okay, the patient is dying, so I need less nursing care. No, it should change. It should become more. But suppose patient is calm, lying down, relatives are there around having their time. Maybe it's time for you to change the position. Maybe we can take half an hour or something, let them have their conversation and then go and change. That is different. But otherwise, there should be increased frequent changing. Rather than asking what is the BP, our focus should be on how is he or how is she. We are not bothered about BP anymore. We cannot have a patient dying with 100% perfect parameters, right? Your oxygen level will fall down. Uh, you will have less sodium, more potassium, you will have less calcium. All this will happen invariably. You cannot have 100% saturation while dying. That has to come down. That is that natural body process. Your liver functions will come down, your renal functions will come down. You can't keep correcting and die in 100% saturation of oxygen. Position change and skin care. Again, there should be a balance between pressure sore and comfort. If the patient is very uncomfortable, you don't need to go and change them every hour. So see if the skin is intact. As of now, there is no problem. Accordingly, you can plan your nursing care. But if there is a high chance of skin break, then maybe you need to give more nursing care. And when you give pressure relieving mattress, I'm sure you had session on wound care. But even if you are giving pressure relieving mattress, make sure that the position is changed because generally the family thinks, oh, I have a pressure relieving mattress. I don't need to change the position. That is very wrong. Again, as I said, they may not be able to close the eyes. Why? They generally ask you why he is not closing the eye. So these are the reasons. There will be loss of retroorbital fat pad. Once someone is dying, someone is deteriorating, there is a natural process which happens in the body. And the length of the eyelid, I don't know how many of you have noticed. I was very curious when I started working in palliative care. Suddenly you feel the eyes are sunken and the eyelid becomes much shorter. I always wondered why this happens. So this is a part of the neurological changes that happens, and there is an exposure of the conjunctiva. Why are we giving importance to eye care? Because they are not closing their eyes, there will be increased dryness and there can be pain, and they can't even tell you because they will be not be conscious. So it is important to maintain the moisture. You can use a lubricating gel every 4 hours, or you can use artificial tears or contact lens solution every half an hour or something. You can instruct the caregivers also to use it every hour so that and just clean and wipe the eyes around the eyes. What happens to pain? How will you assess pain in patients who are dying? Any method that we can use? How will you assess pain when the patient is dying? Anyone? Patient will not talk to you.
We can pinch the ear and see.
Even without pain stimuli, if you pinch my ears, I'll scream. Have you noticed facial expressions of patients with pain?
Yeah, they.
Yeah, Rajeshwari has mentioned that no sleep, restlessness, crying. Yes, that is one way of looking at it. Sometimes even without crying, if you look at their face, there can be wrinkles on the forehead.
Yeah, wrinkles on the forehead.
Right? Because
yes.
they have some kind of distress. May not be
Yeah.
pain. I'm not telling 100% it is pain. It can be delirium. They might be seeing some bad dreams.
Yeah.
Right? But
Yes.
it more or less, this can be a sign of pain. And as I said, you are going for nursing care, you are changing the position, right? That time you can see the facial expression. They'll make some noises while you change the position. Suddenly the facial expression changes, they'll start groaning, they'll make all the unpleasant noise and they'll be restless. So these are the ways with which we can identify. And I always ask of course, I'll first ask the nurse in my IP because they see the patient invariably all the time, right? I'll be seeing maybe once or twice a day. So I ask the nurse, was the facial expression same yesterday? Do you think? I always ask, what do you think? Do you think he has pain? And I rely on the nurse's judgment. And then I ask the family member because they are seeing this patient for a long time, right? So you ask the family member, what do you think? Do you think that he's in some distress? So they say, yeah, generally his expression is not like that. I feel that he is having some kind of distress which is unable to tell. So ask them. There is no shame in asking people around the patient who are much closer to the patient than you. Again, suppose the patient has pain, what should be done with the analgesics? Maybe he is on NSAIDs. Should we continue? Should we reduce the dose? And sometimes people think about putting an nasogastric tube for giving medication. So very often family members tell us, oh, doctor, he's on so many medications. So now he's not taking medication. Why don't you put in a nasogastric tube? So that is something which comes under ethical decision. Is the tube going to help the patient or not? What is a general explanation that you give or you have seen doctors giving while putting in a nasogastric tube to prevent aspiration, right? When someone is dying, the gag reflex is lost. So to prevent aspiration, people encourage, generally doctors, I'm not blaming nurses, they say, okay, put in a nasogastric tube. But do you think a nasogastric tube will prevent aspiration? What about your saliva? What about the normal secretions that you have? You will aspirate, you will have micro aspirations invariably, even if the tube is there or not, you are bound to have aspiration. So nasogastric tube is not going to prevent any aspiration. That is not the reason. That's what we generally tell the patient. This is to prevent aspiration. And many a times the caregivers will have a fear that, oh, what if the pain increases? What will I do? So we have to have a plan in place for them If the pain is increased, this is what we are going to do. Again, how will you assess the pain in an unconscious patient? We can see whether it is a persisting expression, facial expression, or it is just coming and going. Sometimes when they have bad dreams, the expression may not stay for longer. When they have the bad dreams, they shrink the face, then they'll become okay. Check for any grimace or any other physiologic signs. Incident or rest pain. When you change the position, they might feel pain. So then we may need to think how are we going to manage the skin care. And we have to differentiate it from terminal delirium. Even with delirium, patients show all the facial expression, like Sister earlier told, Sister Rajeshwari told, sleeplessness, the restlessness, and etc. It can be seen in delirium also, right? So we have to differentiate whether it is difficult. It is not an easy task. We have to differentiate whether it is pain or delirium. Another important thing. So we have touched upon pain. Another important thing is delirium. So many a times delirium may progress to hallucinations or agitation, and it can be very, very distressing. Have you encountered any patients with delirium which you felt very difficult to manage? Terminal delirium, I mean. Have you treated any patients with terminal delirium, and what did you actually see?
They become violent.
Yeah.
Yeah, they,
How will the family members feel about it? They become a very different person, right?
yeah,
Most of the time in their life, they might have been a very mild, calm person, very sophisticated gentleman, never used a bad word. Yes, Kumari, yes, they won't sleep. They'll be very alert. They'll be agitated all the time. And I've always wondered the magical power of brain because they might not have used such bad words in their entire life. So I have my own relative. He's 95 now. He's a Sanskrit scholar, very well-known person in the community. Now he's 95. He's very old and having all the memory loss and stuff. Now he is delirious all the time. Night and day, he doesn't sleep. He yell at people. He can't recognize anyone. Use all the bad words, which he has never heard in his entire life. So I always wonder where do they get this from? I mean, they've not used or heard these words, and suddenly they completely change, and it hurts the family members. We've seen people, relatives crying, telling that he has not done this. He was a very nice husband. He has never hurt me. Now the kind of word that he uses when I'm near, the kind of abuse that he pours, this is very, very disheartening for them, and they get hurt. And we don't want the patient to die in such a misery, right? But because the relatives are going to remember this part very strongly. That is the impression that we are there, that is going to be there for a long time. They won't get over the trauma. I've even seen patients who had a severe pain and peripheral vascular disease, unable to move from the bed, but he was on end of life care. He always walked with support. He cannot get down or from the bed to the bathroom. He cannot go on his own for the last few days. In terminal delirium, he actually jumped out from the bed, opened the door, and he was walking on the corridor. He went to the terrace, and we thought, how could he walk? He was not walking for months. So it is very, very unpredictable, and it is very traumatic for the caregivers. So controlling or managing delirium, communicating it with the caregivers. He is not abusing you knowingly. This is a part of brain. This is a process. So we have to talk to them regarding these symptoms. Otherwise, the relatives get very distressed about this delirium because they don't understand. They take it personally. Okay, my husband is abusing me. Early detection and management of delirium is very important because untreated delirium, when it comes to terminal stages, it is very going to be very aggressive. And if there is anything we can exclude, any contributing factors, look for it. For example, there can be a catheter which is blocked, look for it. So our primary objective, pain-free, non-agitated, respiratory secretions to be taken care of, no nausea, vomiting, no breathlessness, or no micturition related difficulty in terms of physical care. And what happens next? I always encourage the family members or all our nurses. We talk to the patient, everyone. And many a times the relatives say, no, doctor, he cannot hear you. He's unconscious for the last week. But still, talk to them. Hearing is the last thing that they lose. They keep hearing you. Even if they can't see, they can't sense, hearing is the last sensation that they lose. Keep talking to them. So even if they are unconscious, when the nurse go near them, they ask, how are you feeling today? Can I check your BP? Can I change your position? I'll not hurt you. And all these things they communicate, and the relatives will look at them as like, he's not hearing. Why are you asking permission? It is okay. But we say, no, you sit near them, talk to them. We encourage. Sometimes we use, see, if you compare this with the what happens in a family when the patient someone is dying, some old person is dying. I've seen my grandparents dying, two of them. When they are dying, people chant, no? People chant near them, people use all the prayers when someone is dying because they can hear. They did it for a reason. If the patients can hear. So encourage the family members to sit with the patient and talk to them. Never ever forget to talk to children. There will be children in their family. They may be curious to know what is happening. Oh my God, what is happening? Why this is happening? Ask them if they have any need any clarifications. There are certain religious things that they want to, maybe some last communion. They want to call in a priest and do something. Encourage them. If they want to do it in your hospital, give them privacy. Let them go through the religious rites. And very important, the last step, are we taking care of the emotional health of the carer? Because all the focus now goes to the patient, right? Everyone is visiting. It is exactly like the birth situation. When a child is born, everyone will come and visit the child. No one is talking to the mom because mom has gone through a lot of trauma or a huge process in her body. Sometimes we may not talk to the mom. It is very important to talk to the carer, understand their issues, their dilemmas, sit with them and talk to them. And when I told about feeding, these are the four ethical principles that you need to always remember. It is very important. I know that you might have learned this in your college days, but it is very, very important to keep it in your mind, in your practice, and maybe for the exam purpose also. Four main principles: autonomy, beneficence, non-maleficence, and justice. Autonomy is that patient's decision are the superior. That is the supreme thing. We are not taking any decision for the patient. What the patient wants matters the most. Family is always a surrogate decision maker. Family is not the primary decision maker. Family is always a surrogate decision maker. And whatever you do, if you are giving a medication, if you are putting in a nasogastric tube, whatever intervention or care that you do, the aim is to do good and the aim is to do no harm. That is one thing that we need to. Why every so suppose you are going to do a blood test. Ask yourself, what good I'm going to do with this blood test? What am I going to achieve? Am I going to harm the patient by putting in a nasogastric tube? Or am I doing a good thing? So these are all questions or discussions that should happen with each patient, or sometimes there can be conflict or dilemmas when we take care of patients. Justice, there are two types of justice. I'll tell you an example for justice. If you have a patient who needs 1 lakh rupees for a chemotherapy or an immunotherapy, and you have money, okay, someone gave you 1 lakh rupees, you have the money, so the patient is approaching you, very young patient, I want to take immunotherapy and it costs around 1 lakh. You have 100 patients under your care who needs morphine for pain, which will again, you need that money for taking care of 100 other patients. So that is a place where you need to think, am I going to give this money for one patient for taking care? Yes, the patient is young. They may be, you might be giving a prolonged life with this chemotherapy or immunotherapy. But am I going to take care of 100 patients who are in need of pain relief? So, which is called distributive justice. How many people will benefit with available resource? It also implies many a times I feel sometimes some patients demand a lot of time from us, right? When you are in your ward, sometimes they need to spend or they want to spend more time with you. You have 30 other patients to be seen, right? That is where all these dilemmas come. Am I going to use my time and available resources for so many people, or am I going to be focusing on one patient? So these are things to be discussed in a team and come out with a. So when you are considering what to do, immunotherapy or giving morphine, so we need to think about do no harm. Am I harming these people while I'm giving money for one person? So all these decisions, discussions should happen within the team. What is the intention of a medical treatment or a end of life care? Is it do you think we should preserve life at all cost? Is that our intention? Or to preserve life of reasonable quality with reasonable medical measures? We can't preserve life at all costs. There is a time at which we may need to stop. We may not be able to keep everyone mortal in this world. So it is important to think, I want to preserve life. I should give a reasonable quality of life and I can use reasonable medical measures. I may not go into intense interventions. And who can decide that? Am I supposed to decide that? Am I the best person to decide for a patient? No. Just because that I have a degree, just because that I have a medical degree and I have seen so many patients, doesn't give me the authority to decide for the patient. If the patient is competent, if I am the patient, I want the doctor to ask me what I want. I don't want the doctor to take decision without asking me. It hurts, right? I want to be asked, okay, what do you want? So if the patient is competent, he or she is the person who should take decision. If the patient is not competent, then we should have a surrogate. If there is no one, if there is, you can always check if there is a responsible relative, but at times we will have to take the decision. But you can't give the entire decision making to the patient, right? They are not knowledgeable in the medical field. So you have to provide all the information. Okay, this is the what do you mean by this? Why you are giving this medication? What are the other options? What are the pros? What are the cons? Without proper information, you cannot tell the patient to decide, right? So we have to, as I said, you can't it is not like giving a menu in the restaurant. You have to give what is there. Okay, we usually ask, no, okay, in this paneer butter masala, what all you add? Is it spicy or non-spicy? So they want to know more. So in the life decision, we have to give all the information, but let the patient or their surrogate decide on what they want. Very, very relevant discussion. Decreasing the nutrition or fluid intake. Oh my God, my loved one is not eating. If I don't feed, am I giving up? We tell them, we encourage them not to give artificial nutrition and hydration. Am I starving my loved one to death? Because doctor told not to feed. I had the experience with my own family member. So my uncle was having dementia. He was gradually deteriorating, but the whole family wanted to feed him. I mean, you can't. So there was a huge fight. Everyone is standing against me. Why are you not putting a tube? I mean, he is bedridden for months. He is deteriorating. He has advanced dementia. And they feel emotional because you are telling us to give up, starve him and die. That is not. Food may be nauseating for the patient. So whenever they feed, he ends up in a lot of distress. He starts coughing, he starts vomiting. I mean, so when they insist on feeding, what are they feeding for? They are feeding for themselves. They are not feeding for the patient's happiness. They are feeding for themselves. So I asked, okay, what is most important for you? Feeling good for yourself by feeding, or you are trying to help him? So food can be nauseating. Sometimes the lack of hunger, anorexia is very protective. And there is always a risk of aspiration. And many a times you will see patients will clench their teeth when the food is going near them. They just don't want to eat. Your body doesn't need that much food or water when you're going through end of life situation. But we have to explain the family the situation. You can't say no, no feeding because the patient is dying. That is going to hurt them. You have to explain why. Remind them dehydration is not going to, sometimes it is protective. Too much fluid is not good. Their breathing changes, their secretion gets stuck. They have noisy breathing when there is a lot of fluids, and sometimes ketones when they are not eating. You know that your body will produce ketone bodies. They will go to ketosis. They can be an anesthetic and help them to cleanse their mouth. And they feel thirsty because they have open mouth breathing. So the tongue will be dry, lips will be dry. So you just need to make it moist. You don't need to give water. So make them understand that the body doesn't need fluid. It is shutting down. If you give IV fluid more than required, the kidneys are not able to push the fluid out. You might have seen people become edematous in the end. And as nurses, I'm sure you might be involved in post-death care also, right? When patients are bloated up with a lot of IV fluids, what happens? Lot of secretions come out, and and it actually affects their dignity. So a little bit of dehydration is good. I'm not telling to dehydrate the patient. We can maintain hydration through subcutaneous route, but we don't have to correct the dehydration. We can maintain some amount of fluid so that the skin is intact or they are not dehydrated. But these are all protective mechanisms of body. And we have to explain this to the caregivers. You are not starving them to death. And what to do for the dry mouth? I'm sure you have heard about the baking soda mouthwash with saline and soda bica. So you can give good mouth care. Keep it in a liter of water, apply it, protect the lips and the nasal cavity with Vaseline or any petroleum-based product because they have mouth breathing and that will cause a lot of drying and cracking of lips and the tongue. I encourage them to use ghee also because ghee is very homemade and palatable. Sometimes Vaseline is not very pleasant to be applied over tongue and everything. The tongue will be dry and cracked when they have mouth breathing. So you can tell them to apply honey or ghee. So even if they swallow, it is something which is pleasant and which is homemade. So that is a good remedy and it is easily available also. So have you seen patients having noisy breathing when they are dying? Has someone heard such noises? There will be a lot of noise while they breathe. Very commonly seen. We call it death rattle. Have you heard? Yes. Yes. Thank you, Ashwini, for the response. So why is it happening? Generally, people say, oh, they have chest infection because they have aspirated about. Very good. Ashwini, can you tell me why the secretions? Where is this coming from and why it is making so much of noise? Can you tell me why there is noise? So what happens? Yeah.
Maybe they may be not able to clear out their situation, so they may need assistance. That may be one of the causes. Then other will be, there may be other causes. I can't remember it actually.
No, you are very correct, and someone else have also responded. I think that's I didn't see the name. Yeah, they won't be able to swallow. Kumari, yes. And actually, you're right. That is the only reason. It is like you have a glass of water and you have a straw. What will happen if you blow through the straw? It will make a lot of noise, right? It is the same mechanism. We told that they will lose their gag reflex. So all their oral and tracheal secretions, everything will pool because they are lying down like this. Everything will be pooled in the back of the throat. So, and they are breathing through the mouth. So the air is passing through those secretions. They are unable to swallow. It will make a lot of noise. And why I'm explaining this? We have to explain this to the family. The family will be scared hearing all this noise, right? Oh my God, they will think that the patient is in distress. This is not bothersome for the patient. This is not distressing for the patient. It is distressing for people who are listening to it. They will think that the patient is suffering. So you can't, they expect an explanation, right? So this is a very simple thing. You tell them, Pool of water, you blow through the straw, there is a noise. So it is very important to make them understand in their language. So there is a lot of secretion. They are unable to swallow. When they breathe, it makes noise. And how will you treat them? Very simple treatment. Change the position. The positional drainage is the best way of doing it. Change the position, side lying position. Generally, it will get drained. But stressing, we can always use glycopyrrolate. I'm sorry about the dose because this is from a Western textbook. We can start with 0.2 milligram. That is 200 microgram. It comes in microgram. You can use 200 microgram. You can go up to 1600 microgram in a day. So you can 0.2, you can repeat every 4 hours. You can either inject glycopyrrolate subcutaneously or you break the ampule of glycopyrrolate and tell them to give it sublingually. If they are at home or even if they are in your hospice, why do you want to prick simply for secretion? You can always break the ampule and pour it under the tongue. It will reduce. So local application or subcutaneous application. And someone mentioned about change in breathing pattern. Explain the family there will be change in breathing pattern. It is not because that they are breathless and they are getting suffocated. It is a natural change in the pattern of respiration. And how will you help? Again, informing the family that this is natural and expected. Opioids will help a lot in breathlessness, which you have already learned in respiratory symptom management. Oxygen is very, very debatable. Oxygen may prolong the dying process, and it is a natural way of shutting down of the whole system. The body will not be able to utilize oxygen, even if you're giving it artificially. Again, you cannot have a person dying with 100% saturation, right? The oxygen saturation will invariably drop when someone is having a natural death. Again, I'm coming back to delirium once again. You can have two roads to death. One is a very difficult road, which is having a hyperactive delirium. That is not something we want to give to our patient or the family members. They'll be restless, hallucinations, jerks, seizures. We don't want to do it. And there is a usual road where there is a hypoactive delirium. The patient will be calm, sleepy, they'll be semi-comatose, they'll be, by and large, they'll be calm. So that is hypoactive delirium. That is a very usual road. So this is a card. If you Google Palmet, these are certain cards that you get. This is very useful. It is just a reminder or summary of things which we can remember when we are dealing with such patients. Again, communication with the unconscious patient. As I said, they can hear, and we know that brain functions very, very differently. There are different areas for hearing, responding. So they may not respond, but they can hear. The awareness may be decreased, or the ability to respond will be decreased, but they are aware of what is happening around them. So encourage them to have the communication. Just yeah, sorry. Again, if you the patient is dying in hospice, try to create some familiar environment. If you have monitors beeping all around and unfamiliar people coming, that's a little distressing for the patient. Assume that patient hears everything. Don't have conversations when the patient is lying down there. Have all these conversations with the family members. Have good conversation, not talking medical things in front of the patient. And encourage touch. Have the caregiver sit with the patient, touch the arms, be with them, involve them in the position change so that the physical touch is maintained. Have you ever thought about the permission to die part? I very often have noticed sometimes the patients who are dying a prolonged pathway, we think that okay, they will die this week, but they will be there, there for days. And when someone comes to visit them or something happens, then they die peacefully. So we always feel they were waiting for something. And when that happens, they die very peacefully. Till then, they will just pull on for. Sometimes the son will come from abroad. They have some time, and then the patient dies. So I'll tell you an example. One patient who was going through a lot of distress, and then we came to know that this patient has not. So patient is unconscious, going through end of life, pulling a lot. We thought he's going to die sooner. Then the wife told he has not talked to his brother for last 20-25 years due to some silly fight happened in the past. Then he called his brother and asked whether he wants to come. Can we think about coming and meeting? Because the patient is going to die. You may not have enough time for forgiveness. And this brother came, just sat there for some time, and the patient passed away so quietly. And sometimes I have felt that the relatives will hang on to the patient for, they don't give that permission to go. So it is very important to assure the family, be with the family, and let them go. The patient may be waiting for the family to accept their death. I don't know how to express that in words or in theory. This is not from a textbook experience, but many a times they will be waiting for something. Maybe they need to hear from the family member, okay, we are ready. Or sometimes we do some rituals, like in my religion, we do gives holy water from Ganga, and we do some prayers, and then they pass away very peacefully. So there is something called forgiveness or preparedness for the patient to die. So, or giving all this chants and holy water and prayers, it's actually telling the patient that we are ready or you are ready to leave. That is also very important. Give the permission to die and say goodbye. Many a times, if you start noticing, they will wait for that one moment and then they die peacefully. So that is also very important. This is a card. I'm not explaining anything in this. You'll get this presentation. Again, if you search PALMED, it is an organization for advancing palliative care globally. It is free of use. There is no copyright issue. So how they have written how we manage the dying process. What about the skin care? What about the oral care? What about the lip care, eye care, etc. What all should be done? How will you check the urine output? How will you manage the dyspnea? All this will be given in this card. This is one important message. Everyone remembers the care during the last hours of living more than any other time, right? No matter how much, how much ever good drug that you are giving, how expensive chemotherapy drug you are giving, they will not remember that. Oh, my doctor gave the most expensive drug. No, everyone remembers. Just give me. Everyone will remember what you have given when they are dying, what memories that you have given while they are dying. And especially when you have time to have all these conversations. Sorry, I just. So again, never forget children. There will be children in the family when someone is dying. Talk to them, explain to them what is happening, and make them understand because they will have a lot of questions. I'm not touching a lot upon withdrawal of artificial life support. I just wanted to say that withdrawal of artificial life support, if the patient is not going to benefit from the artificial life support, when you want to withdraw, you are not killing the patient. You are stopping something which is futile, which is not going to help the patient. And you are not taking decision on your own. You have a medical board there. You have the family members there. If you think, as I said, beneficence and non-maleficence, if you think that this is not going to help the patient, withdrawing the life support is not euthanasia. Euthanasia is something when you deliberately inject something with an intention to kill the patient. When you withdraw something which is useless, it is not killing the patient. Your intention is never to kill the patient. So withdrawal of artificial life support or any futile treatment is not euthanasia. And in India, we don't do withdrawal at all. See how often it happens in other countries. Here, we don't talk about it. Once they are in ventilator, they are in ventilator till they die. And when one relative come, okay, let's switch off the ventilator, like in movies. That's not how it is. You have to have first of all, You prevent people ending up in such condition. But if someone is on artificial life support and it is not pulling it through, let's have the conversation and go through the withdrawal process. And with this last slide, I'll end my presentation. This is an advanced medical directive or living will. We have a document in our website. We are updating it soon, within a week or two, and create the document expressing the wishes. This is not just for your patient, for all of us. Get it countersigned by a gazetted officer or get it notarized and keep it with your medical records. You can't keep it as a secret. Better you have a discussion with your family members about that. This is my wish and this is something which I want to do when I am having end of life. This is how I want to die. So this is something we should encourage people, our patients with advanced illness should have, or all of us should have in that matter. So I'll end my presentation here. I'm happy to have questions. I think I took a few minutes extra. I'm happy to have questions.
Thank you so much.
I hope these points will be helpful and you will keep this in your mind when you are treating patients who are dying. These are small points, and as I said, nurses play a major role because when someone is dying, it is not my medication that they prescribe is going to be remembered. It is about how you talk, how you took care of the skin, how the patient is clean. Like you don't want your loved one to be stinking when they are dying, in urine and fecal matter and bed sores. That's not what you want. They have to be very clean and dignified, right? That's nurses play a major role in keeping that that dignity.
Ma'am, excuse me, can I ask a
Show me,
question?
please. Yes.
Ma'am, advanced medical directives, in that you have mentioned create a document expressing wishes. Can you say
Yes.
an example?
So there is a document in our website. If you get into Pallium India's website, if you type living will, there is a document available in our website. We are updating it soon because there is a recent Supreme Court judgment which happened few months back. So based on that, we are and if you read a little bit about, so there are a lot of organizations in Kerala. They arrange these living will campaigns. So they bring together 100, 500 people and all of them write their living wills, get it notarized, and make sure that okay, my end of life care is planned, which is documented. So if I have written, I don't want, if I have advanced cancer, if I'm in a road traffic accident, I want my physician to put me in ventilator. Maybe I'll come back. That is a different situation. But if I have an advanced illness, I don't want, I know that I'm dying. I have an advanced lung cancer, then I know that I'm dying. I don't want to be in a ventilator. So I will write it down. I will inform my family. See, these are my wishes. I will ask my physician. I am a lay person. I don't know whether I can get benefit or do I need inotropes? Do I need dopamine? Do I need to be shocked? Do I need CPR? So I recently talked to a medical student whose grandfather, who was 80 plus in India. So this guy is from US and his grandfather was in India. Attempted CPR for long time, lot of broken ribs and ended up in misery. And he had, so it is very important to have this medical directive. The document is there in our website. We are updating it in another 2 weeks. So you write it down and get it notarized. There is a big movement happening and we'll be organizing a webinar very soon in the first week of July on how to write an advanced directive or a living will for yourself. Until and unless we do it ourselves, we don't know how to what to tell your patient, right? They will ask many questions. So I always say, okay, we have an advanced or living will. This is how it should be done. So we'll have a webinar soon, and that will be more. Then the document will be final. But for a template, you can refer to the current template in the website.
Thank you, ma'am.
Thank you, ma'am, for the excellent presentation. Can we move on to the case presentation?
Sure, please.
Okay. So, Sangeet, Miss Shiny Thomas will be presenting a patient story today.
Okay, ma'am. I'll share this.
Okay, okay, thank you.
Good evening to all. Am I audible?
Yes, sister.
Yes, yes, you are.
I'm Sister Shaini, a staff nurse. My patient's age is 57, gender male, diagnosis glioblastoma, right frontal. Present complaints: hemiparesis left, aphasia, fear and anxiety, breathing difficulty, overeating, restlessness. History of illness: 57-year-old male patient. He is married and have 2 children of age 10 and 5. Had 2 months history of progressive headaches, which became more frequent and severe over time. Had also complaints of nausea and vomiting. In the last months, he had some changes in behavior such as memory lapses and difficulty in finding right words, weaknesses in the left side of body, and gait disturbances. Initial medical history: MRI revealed a 6 centimeter mass in the right frontal lobe, confirmed as glioblastoma by biopsy, and he underwent gross total resection of the tumor, followed by chemotherapy and radiotherapy. The tumor recurred within 6 months. An examination: was alert, oriented, was tired and restless, limping on left side, sensory, intact to light, touch and pinprick. His weight was 50 kg and temperature 98.6 degree Fahrenheit. BP 140 by 90 mm of Hg, pulse 88 per minute, respiration 23 per minute, and SpO2 88%. On medications: tab levetiracetam 1500 milligram BD, tab lorazepam 1 milligram TDS, Novalgine drops 40 drops TDS, hydromorphone 2 milligram HS, Dexa 12 milligram OD, pantoprazole 40 milligram tablet before breakfast, and nebulization TDS, and intermittent he got oxygen 2 liters. Psychological aspects: patient is 57-year-old married man who is a physiotherapist by profession. He lives with his wife and 2 children of 10 and 5 years old. And children, they don't know about the seriousness of his illness. His mother and wife, they are involved in caregiving, but mother and wife are not understanding each other. And even being physiotherapist, he knows about his condition and prognosis. He's irritated, anxious, and restless, showing always dissatisfaction, overeating, anxious about his children and wife. Summary: a 50-year-old male was diagnosed with glioblastoma, an aggressive and malignant primary brain tumor. Despite undergoing surgery, chemotherapy, and radiation therapy, his disease progressed, giving a poor prognosis with a short life expectancy. He is currently receiving palliative care in a palliative unit. Discussion points: what psychological support should be given to the patient and his family regarding end of life care, and how can we address the emotional and mental health needs of both patient and his family for coping with the knowledge of his terminal diagnosis, and how can we improve the quality of life by balancing aggressive treatment versus palliative care, respecting the patient's wishes and decisions regarding their care. Thank you.
Thank you, Sister Shaini, for the excellent patient story presentation. I hope this presentation is clear to everyone. I think we can move on to the discussion points. I would expect from a small request to the participants. Please unmute yourself and talk. We are in the end of the session. So I think the end of life care and ethics class is over now. So I think you are the person to answer now. And we want to add anything, we will. I think just to share your thoughts first. Please unmute and talk. We all are nurses. Please. The first question is, what psychosocial support should be provided to the patient and his family regarding the end of life care? So what do you think? How can we help?
Ask the family how much they know about the patient situation, the disease condition of the patient.
Yeah. Thank you.
Then,
Mm.
then continue the psychological support. How much if the patient now here the patient is physiotherapist, he may know certain most of the prognosis of the illness, but the wife and children, especially the wife, children are not that grown up to understand it. I think the wife must be told clearly.
Yeah, you are correct, sister. As we always discussed earlier also, we have to find out their insight first, what they are understanding about the disease condition. This patient is a physiotherapist. He might be know the prognosis and diagnosis and prognosis. So at the same time, the family is going to lose their loved one, like husband, and the children are going to lose their father. So that is the mainly the loss. Loss is always a what it's like a feel like nobody is there to take care of us. That kind of feeling will be there all the time. So we are the person to sit there, sit near to them and listen there and explore their anxiety. And definitely we have to explore their insight. If there is any collusion breaking or anything there, definitely we need to break the bad news as a using a spice protocol. We already discussed that. We already learned about spice protocol, how to communicate a bad news with the patient and family. These all things we know. So we have to use that things whenever we have in a these kind of situations. I think ma'am, do you want to add anything? Are you there?
No, there are other comments in the chat also that there should be some counseling, reduce the fear. Lot of comments I was just
Yes.
reading. It's difficult to give support because he's a physiotherapist. Still, we should explain the situation in a calm way, provide education to the family, reduce fear. That is very, very important. Reducing the fear. There will be a lot of fear because it suddenly happened and he's young, has 2 children. So there will be a lot of fear. How, especially knowing a little bit about the prognosis, maybe there will be a lot of fear among the patient and the family members. So provide time to sit down and let the patient to express his feelings. Yes. I'm just reading out the chat, helping them to come terms with their mortality with proper communication. Yeah.
Thank you.
That's
So yeah, as already we discussed earlier, he is a physiotherapist. He might be know everything, but at the same time we don't assume anything, but you have to sit near to him and listen his anxiety, and what is the more worry, which one is the most important. Sometimes he wants to achieve, maybe meet something like that kind of things will be there sometimes. So at least you have to be there, and at the same time you have to be talk to the family, and you have to convey that message like we are here to support you. So even if he died, like maybe he died soon, so after that also we will be there for your family. That kind of positive message you have to convey. Okay. And also you have to think about the children's education. So if there is any difficulty facing, we can able to help the children's education. So that also you have to think about that, and also bereavement support after death. We have to visit the family if possible. Otherwise, we can make a phone call and that ask them. So you have to find out how can they live nowadays. Is there any psychosocial distress, anything? So you can able to if you are not able to go to the family, you can include the community volunteers. If it is there, you can try to involve the community volunteers there, and they can go there and see the family and inform you what is the condition. Okay, thank you. Ma'am.
No, I don't have
Okay.
anything else to add.
Okay, so thank you, ma'am, for the excellent presentation. Thank you, Sister Shiny, for the excellent patient story presentation. So this is our end of the course. This is the last day of our course. So we expect some your feedback. So your feedback is very valuable for us to improve our quality. So please share your feedbacks. At least 1 or 2 participants. Uh, please share your feedback.
Yeah, I am the Sister Tabitha from Shanti Awareness Southern Delhi. I just wanted to say that it was an excellent presentation for all through the classes. And what would I say? The presentation of the cases also was excellent. And I could benefit a lot of things, though we are working in the hospice. I could benefit a lot of things and clarify my my doubts and all that things. I congratulate the participants, not the participants, congratulate the resource persons, all those who have presented the programs. Thank you very much.
Thank you, ma'am. Thank you for your nice words. Is there any suggestions for improvement?
Yeah, I did not think of those. I will send a mail to you.
Okay. Thank you. Thank you.
Yeah, thank you.
Okay, thank you. Anybody else?
There are a few comments in the chat box as well, ma'am.
Okay.
Rajeshwari said that we learned more information to implement patient care. Thank you so much for all our pallium care team. And Rosama Joseph, this is a wonderful learning experience. I felt part of this community. I learned a lot. And just like that, a few more responses are coming.
Okay, thank you. Thank you for sharing this nice words. So anybody else want to share anything? Okay. Thank you. I saw some messages also through chat. So thank you for your participation. So my request is, I understand that you have learned many things from this course. Each session will be beneficial to you, but my request is to try to implement, try to include the palliative care, the total care aspects into the patient care. So whenever you have seen a patient, you have to keep it in mind all the 4 aspects. Okay. So if you have any difficulty or any problem there, please call us. We will help you. We have a telehealth department. We can able to connect with them so that they can make a video call and see the patient and help you. So if you need any help, please don't hesitate to contact us. Anytime you can contact us. Thank you. Best
Thank you.
wishes.
Thank you for your assurance. Thanks a lot.
Thank
Yeah.
you.
Thank you, ma'am. Thank you, Dr. Sreedevi, for the wonderful sessions. Thank you, Shiba ma'am, for facilitating the session. Thank you all for giving your valuable feedbacks to the sessions. So with that,